Are we ready? Live?
We are live, sir.
Okay. So, good evening, postgraduate, and welcome to this 99th episode of All India Ophthalmological Society Academic and Research Committee's online PG teaching program. This is a PG program with a difference because we try to cover the subjects which are not routinely available with other postgraduate teaching courses. Today's episode, we are going to discuss on causes and problems in management of childhood blindness, and who is better than Dr. Rohit Khanna to discuss this, who himself is a network director, public health consultant, ophthalmologist, and a glaucoma specialist at LVPI Hyderabad. Also, most importantly, he is a dear friend of mine and my school buddy. We also are proud to and privileged to have other discussants, Dr. Praveen Vashisht from RP Center, Dr. Subhashini from JIPMAR, and Dr. Mary Frederick Motappa from Arvind Eye Hospital, Chennai. So without much ado, can I request today's moderator, our member ARC West, Dr. Anaga Heru, to carry forward the proceedings? Anaga?
Yes. A very good evening to one and all, and a warm welcome to the AIOS ARC webinar. We're really fortunate to have an excellent speaker and a great team of expert panelists today. And this is a topic which is a very offbeat topic, which was asked in one of the exams. Thought we would have a great talk on this. So I'd like to request Dr. Rohit sir to please share his presentation.
Sure. Thanks Prashant, and thanks all the panelists. And this talk is about childhood blindness in India, and the topic was given was like causes of childhood blindness. So I thought I will start with childhood blindness in India and what are the causes in India. And at the outset, I would like to acknowledge the support I received for making this presentation is from my mentor Claire Gilbert, and to some extent Dr. Vijay Lakshmi from Arvind. So probably I think
All good, doctor.
Are the slides visible to everyone?
Perfect, sir.
Yeah. So I think this is something which you keep seeing when you go to some school for the blind, or you go to some hospitals where you go to rehabilitation center and all this. And we keep on thinking like why these children are blind. And there are always myths and beliefs actually in the community that, for example, if you take strabismus, they say it's a sign of good luck and they don't get it treated. And it's sometimes they feel that it's not a sign of vision loss also. So many times we see in our community, they say it's a good luck sign, so should not get treated. And then there is again myth about that younger children should not wear spectacles. So probably I think which is not true. And the earlier you wear, the better it is if you have refractive error. So, and then cataract and glaucoma, the community feels that it's a disease of adults and not for children. So probably I think which is again one of the myths which we have to take care of, because and then sometimes they feel that people who having cancer or white opacity in the eye or corneal opacity, they feel that it's a curse of God or something. God has punished this child for all this, whatever they have done. And this again kind of retinoblastoma cases we see, and all these cases, the belief in the community is that it's a curse of God, which is not true. And other belief myth is that children should not be operated unless they are adults. So probably I think many of the communities, they feel that we should not operate this child unless they become adult, because children, they don't undergo surgery. This belief is changing over a period of time, but still I think in some communities it is still very prevalent. So these are the kinds of children we see in our clinic day in, day out. And I will just skip this. If you look at childhood blindness, so when Vision 2020 was launched in like 2 decades back, some of the conditions which were priority for Vision 2020 was cataract, trachoma, onco. I think many things we have controlled now, but childhood blindness and refractive error was very prominent that time, and now also it is very prominent. And why do we children get blind actually? So why childhood blindness is one of the priority? Why should we take care of? Because there are so handful of children. why should it be taken care of? Why should we take care of children? You say there are 10 adult, it's very easy to operate adult cataract, and there's so much of energy involved, or so much of work involved in getting a child, treating him, and then following it up also. It's not like adult cataract, you operate and leave them and they are fine, but you have to keep following these children for lifelong. And many of them feel, why should we get into all this? Better do a adult cataract and get away with our money and then finish it off. Why should we get into all this? But childhood blindness is one of the reasons why it is priority, is because their causes are very different from adults. And many times blind children are more likely to die. So they say average lifespan of a blind children is 45 years, whereas a normal adult is almost 70 to 75 years. And if they are blind, they live with large number of blind years. And we have seen that it's a burden on the parents also. And they require very special expertise to treat. And sometimes if you don't treat properly, irreversible myopia also sets in. The magnitude is not very clearly known because we don't have population-based studies. Recently, we got some of the studies are based on school eye health, but I think school eye health study will not give you the magnitude of problem which are happening in children. So if you want to have a real picture on what happens, what is the magnitude of childhood blindness in the community, it's school, you have to do a it's purely population-based study and not a school-based study. School-based study will give you only more of a refractive error. But other causes like retinoblastomas, congenital glaucomas, and cataracts and all, and children with low vision and all, you will not be able to find in the school, which normal school. So what they say is number estimated. This is a very, very crude estimate that at 50,000 new cases per year is the number of new cases which are coming up each year. This was a very, very long back done study by Claire and all their colleagues, and they found that they had just made a guess about this. Like this is just kind of an estimate where they say 500,000 new children are every year added, and which is one child per minute, and every over 50% of die within 1 to 2 years of becoming blind, because basically because of measles, vitamin A deficiencies, and also half the children don't even see the whole childhood lifespan also. So that's why they say the prevalence in childhood blindness is a very, very underrepresented, because many of these children will even die because of measles, vitamin A deficiency, infections, and all that, diarrhea, malnutrition, and all. WHO has classified the causes of childhood blindness into two categories, which is anatomical, which depends on the site where the etiology, the site where the which is affected, or based on the etiology, which is based on the different types of hereditary, intrauterine, and all that. So this is basically a slide which long back Claire used to show, where this is EME, is Eastern Mediterranean established market economics. Then FSC is social economics, Latin American countries, Middle East, Caribbean, China, India, African countries. So probably if you look at all these causes, if you look at the whole globe is very common, especially from the rich to the poor. If you look at more of corneal causes increases when you go to Africa and China, India, and all that. And the retina causes are almost same across all the ages. There is some change happening because of immunizations of measles and all, the corneal blindness is coming down in India, but still in Africa and many other parts, we see a lot of cases of corneal blindness also. Cataract is very common. So we recently did a study in our state also. We found that in a state of Telangana, where it's not a very well-off state, we had still corneal causes and cataract. And when went to Andhra Pradesh, it was more of retinal conditions and untreated conditions, which are more common. In terms of the etiological causes, it's hereditary, intrauterine, so where they got the infection. Parental childhood are unknown. So half of nearly 25% are hereditary, and 50% of time you don't know the cause. So it's most of the time the cause is idiopathic, especially even if you look at pediatric cataract, many times the cause is not known. It's rubella and torch and other infections and all, but many times you will not even able to find the cause in children with pediatric cataract. So in terms of, unlike adults where 80-90% of childhood blindness is avoidable, in children it's only like nearly 50% is less than 50% is avoidable, which is preventable and treatable. Avoidable means preventable and treatable. Preventable means you can prevent before the onset. It's like measles vaccine, immunization with vitamin A supplementation, immunization with measles vaccine. treatable is like pediatric cataracts and all. So, and most of them are unavoidable. The prevalence is a very, very crude way of estimating prevalence. If you don't have any data in the country, so probably still we can use this formula which Claire had mentioned, suggested long back, and it's high income 0.3 per thousand children and very poor is 1.2 per thousand children. This is the same graph which shows that the childhood blindness is the prevalence of childhood blindness is directly proportional to uh, uh, the under 5 mortality in a given country. But it may not be true for all of them. But and these are the number of children based on the total number given for 1.4 million. Recently, the number has changed. It's 1.2, 1. I think it was 1.2 or 1.1. Praveen can correct me, but it's 1.26, I think, or 1.14 something. But the number are not number. More important than number is basically it's like the more common. It's in sub-Saharan Africa and countries like India and China, where it's like almost 1 million, nearly million of them. So India carries a burden of almost 25% of the world global burden of childhood blindness. And as the demographic is changing, many of the countries are not the age group which is there is a change in demographic where you are more it's becoming a more of a horizontal kind of a pyramid rather than a rather than a pyramid where the children are and young population is more at the bottom of the pyramid. So causes basically again cataract, glaucoma. I will just so it's in terms of number of blind years, it's like a child if he lives 50 years average lifespan, and if you have 1.4 million, so it is 70 million blind person years, which is cataract. If you say a person with cataract lives 6 years, so and you have 20 million. Just because this is just illustration to show you like how the number of childhood blindness cases of childhood blindness can vary in terms of number of years. I will just skip this slide and again I'll skip this is again we have discussed with under 5 mortality how it varies and I'll skip this. Also, this is basically what we see is cataract, glaucoma, and hereditary retinal disease you see everywhere. Measles, vitamin A deficiency are more common in our country in the rural areas, but in urban areas now you are seeing ROP also as very common cause of blindness. In India, this is the demographic of India, and we have a national program of blindness which addresses the issues of even takes care of childhood blindness also. It's not moving. Yeah. So India, the estimated number of children blind is like 6.5 per 10,000 children, which is almost 0.26 million children are blind. And this is a paper which was published by Dr. Shamna long back, which shows the economic impact of blindness in terms of the life years lost because of childhood blindness. This is prevalence, and so India is like a nation. I call India as nation within nations because you have so many states. Every state is a different. In state there are districts which are very different. There are states which are very affluent like states like union territories like Delhi and all are very affluent, and states like Bihar or Northeast or J&K, they are very, very poor states. So there is a lot of variation in India. So I will not say that India is one. You can't say extrapolate a prevalence in one state to other state or even one location to other location actually. So probably I think we have to look at state-wise. For example, Kerala, which is very affluent, so the causes may be very different. And to a state where like Bihar or Chhattisgarh and all you go, the causes will be very different. Probably just like we saw in Telangana and Andhra, so probably causes will vary from which state you belong to also. Overall, these are the studies which were done in India in the past, and it showed that 60% were unavoidable, so only 40% was avoidable, and cataract was the most. Cataract and congenital globe anomalies and corneal diseases were very common in the past. And basically, these are the causes, which is this more of like community-based causes, basically poverty. So more the health status of the population improves, so many of the causes disappear. For example, now trachoma is totally disappeared from the country because of efforts from all the stakeholders who have taken part in the active trachoma elimination program. So this is basically from in terms of giving an idea about what could be possible causes from the society point of view, from the healthcare point of view. What are the causes for childhood blindness? Basically, it's poor primary eye care, cultural practice, poverty. These are all like risk factors, you can say. probably, and I won't go into details of that. But with so many ophthalmologists in India, so we now have the data on the pediatric ophthalmologists. Recently, we got published, but still the number of pediatric ophthalmologists are very low in this country to deal with all the cases of childhood blindness in this country, and many of them are located in urban areas. And present scenario is lack of awareness, and primary eye care is almost limited to school screening and outreach activities. I will just skip this again. We have the same slide. Basically, more of like prevention point of view, basically in terms of vitamin A deficiency, it's more of vitamin A prophylaxis, measles program, and school eye screening programs and public awareness programs. Then in terms of developing pediatric ophthalmology units, I think Orbis has taken a significant lead in the country to develop multiple pediatric ophthalmology units and funded almost 50 to 60 of them in the country, which has at least strengthened the pediatric eye care services in the country. And a lot of credit goes to Orbis and probably other stakeholders, other institutions which are providing fellowship programs in that. But still, we are yet to meet the need. I'll skip this. And I think school screening program is a very, very well established program in the country. And it's we have a lot of established system for school screening program, and there's all set protocols. NPCB has the guidelines long back they have published, and it's a regular phenomena which National Program for Control Blindness looks at data every year on number of children screened and given glasses and all. Glaucoma and cataract, basically a lot of understanding on etiology of congenital rubella syndrome. So anesthesia, availability of good neonatal anesthetics, neuroinduction and maintenance of drugs, laryngeal airway marks. So basically these are all required for dealing with the child with cataract and glaucoma. And especially even with the post-cataract surgery, you require a good correction of glasses also. In terms of NICUs and retinopathy of prematurity and all, just a minute, it's not moving. In terms of ROP, probably I think we have now good NICUs and taking care of children, and we have good system of developing like the program developed in Karnataka by Narayan Netralaya and probably other institution by LVP, Arvind and all. There's a good program for screening for ROP now available, and even the pediatricians are coming up for ROP screening for their newborn babies. In terms of retinoblastoma, I think again we have good chemotherapy, and now we have good drugs in terms of intraarterial chemotherapy and all also available. So the prognoses are improving. We don't see this exophytic kind of retinoblastoma. So they are picked up at early stage. And into contrast, when we were in countries like Africa, Liberia, when we saw most of the time we see is exophytic type of retinoblastoma. But here, because of awareness and because of good primary eye care services available, we are able to pick up retinoblastoma at early stage, at least save the life of the child. So in terms of rehabilitation, I think it was initially we started, LV Prasad was the first institute to start rehabilitation program in the country in 1987. The day it started the hospital, and subsequently now it's many institutes are providing rehabilitation, especially multiple rehabilitation for children with multiple disabilities also, which has improved the quality of life of these children also. So I will not go into all this. These are basically strategies to what should we all do basically towards one thing is awareness and prevention. More of required is creating because it's very difficult to find a child with the visual impairment of blindness or glaucoma or cataract if you go and screen them. So it should be something key informant approach people have used in the past to identify these children. And there is RBSK scheme also, which is trying to develop health, trying to screen, identify these children with visual impairment. RBSK team is very active in the rural areas and try to identify children with visual impairment. And we get a lot of support from that team in our hospitals, which are in the rural areas. So they are doing a pretty good job. And there are health centers also. So probably I think more should be done at primary and secondary level to identify these children. But in terms of treatment, it's mostly at tertiary care. So probably I think prevention is a key where you can find children, get vaccinated with measles, take care of vitamin A deficiency, which is still common in many of the states actually. Government has a good vitamin A deficiency program, but I am not sure how active it is in all the states in the country actually. And then school screening is very common. So school screening is the second way where you can identify many children. And the key informant approach is it's very well established approach used in many countries, started with Bangladesh, and now it's being used in many other countries. And so that is something which we can try look at to identify these children. We have good protocols for management of these children, but probably I think whenever you see a child, it's always a tempting that this is a cataract I can remove. So probably if you are removing a cataract of a child, so you should make sure that you have a regular follow-up for his lifetime, because this child are likely to develop PCO, amblyopia, glaucoma. There are so many things which these children can develop. And we have seen in our population itself, the pediatric glaucoma is almost 30 to 40% of child over a period of 10 to 12 years develop pediatric glaucoma also in these children, especially if they are aphakic. Now we have intraocular lenses, but I think in the past, many of the aphakic children went into developing glaucoma. So a regular follow-up is required, because you may have to do glaucoma medical treatment, surgical treatment for glaucoma, which is very, very complex glaucomas for these children. So don't think that pediatric cataract is like adult cataract and we can operate. So that sometimes we feel that this is a small child, we should operate, but please don't touch it unless you have very confidence that you can follow up the child for his lifelong, for the entire life of the child. So I think this is what I think what we see. Still, we are in this stage where we see the best of the best Western countries and still the worst of the we are the something like worse than African countries or many of the poor countries, and we see best of we have the best of the best in urban areas also. So this gap is still increasing in Asia and in Western Pacific regions, and probably I think we have to balance, because the causes are different in the areas which are very affluent versus the causes are very different where the areas are very poor and very backward. So I will just stop here, because this is basically a district level program. I won't go into details of the district level program. I will stop here and see if there are any questions to be taken care.
Yeah, thank you, Dr. Rohit sir, for such a lovely presentation. I would like to request the panelists also to give their inputs. Yeah, very warm welcome, Dr. Frederick, Dr. Subhashi ma'am, Dr. Praveen sir. Your inputs also, please.
As Sat told, I would fully agree that there are a lot of variations in the different levels at different areas. Some places like in the south, we are finding more of traumatic cataracts becoming more common than congenital cataracts. The incidence is coming down, but we are finding newer diseases like refractive errors, allergic conjunctivitis, leading to keratoconus. Incidence of keratoconus is rising. And also ROP, still we have a good system for recognizing these children. But CVA is in the rise because of the developments in neonatology and all. We are seeing a lot of CVA patients. So how to handle them, how to train people to even test these children as to what vision they are having, how to train them. So all these things are still a lot of challenges. And I also got a chance to work in UP in Sitapur and Lucknow, and also in the Northeast. So there we see that the incidence of congenital cataract is more, but we have very less trained manpower. So pediatric ophthalmologists who do surgery as such are very less. So even though they have equipments like vitrectomy, phaco machines and all, trained manpower is still a problem in different parts of the country. So when you speak internationally, you also had a chance to work in Nigeria. So there the issue is, as I told, the cost of surgery is very high, very less trained manpower, and the equipments also, they don't have vitrectomy machines. They are very less qualified anesthetists to give proper anesthesia. So even though we feel that the national program of blindness is addressing cataract at one level very nicely, the different areas in pediatric cataract needs to be still addressed. Even though Orbis had really worked hard to set up a very good system of pediatric ophthalmologists. I think we need to build up on that also.
Very well said.
Sir, one question. Okay, sorry.
No. Actually, I just didn't touch upon the non-blinding conditions. So very well, I think you brought up a very important point, the allergic conjunctivitis and keratoconus. And we usually say a lot of red eyes actually, and these are cause a lot of disability. We feel that it's not causing any problem with the children, but there is a lot of disability, school dropout, school performance goes down, probably their academic scores also go down. We are doing a study on looking at the academic scores of children with red eye versus children with not with normal children, and we are seeing that the academic scores of these children are not very great as compared to what their other counterparts. So probably we may do a trial and see whether it's like really intervention can help these children to improve the academic score. The other thing you pointed out was CVI. I think CVI is very common now. I think awareness about CVI is increased. It was there in the past, but people were not aware of, including the healthcare professionals and ophthalmologists were not aware of. So now the awareness among the ophthalmologists has increased for CVI, and we see CVI is one of the, we published recently a paper which was on special school, and we saw almost 40% of causes were because of CVI. So that's a very, very important point. And I think trauma, I didn't touch because trauma is something which is very preventive, and probably when of these children play with pencils and all in the school, I think that should be something health awareness talk we should take care of and make sure that these children don't injure each other, especially more common in boys than in girls.
Yes.
Sorry, Dr.
And also during this Diwali cracker bursting, we have a
Cracker
very huge, quite a number of children losing vision because of
trauma is a like separate, total big separate area in children which may not cause bilateral but unilateral blindness or visual impairment also. Yeah, Dr. Heru, sorry about you were saying something.
No, I was just mentioning just 2 points. You rightly said, sir, about the pediatric cataract. So, what do you suggest? Should a pediatric ophthalmologist operate a cataract or a cataract surgeon operate the pediatric?
A cataract surgeon can operate as long as they are able to understand the nuisance of pediatric cataract, and they can follow up them over a period of time and ensure they take care of amblyopia. They have a system for taking care of amblyopia treatment of these children. And also, glaucoma is very common in these children over a period of time. If they're not able to come, then you have to call them and make sure that they come for follow-up because they may not understand. The parents feel their child is seeing well now, why should I go?
Yeah.
Adult
And
is they can see
how
well,
do we,
but fine.
as a this thing, how can we involve the parents and the teachers also to improve the awareness in society?
It's basically more of like health awareness. Teachers have a very important role to play, and probably the children will listen to teacher. If the teacher can say, if they find any child with this kind of who is not able to move around in the house or any in the village and all, probably why don't you take them to a healthcare center? It's more of like teacher and families, of course, play important role, but awareness in the families. Now we have a good network force of primary healthcare worker, which is ASHA worker, I think, and Praveen is a very hot topic of like very interesting topic for Praveen, and he is very much involved with this in what role ASHAs can play in eye care, and probably I think he is the best person to give insight about the role of ASHA. How can they help in this area of childhood blindness for picking up these children, which is kind of a key informant for us.
Dr. Praveen, sir, please.
Yeah, thank you. Thank you, Dr. Rohit. In fact, a wonderful lecture. It reminded me of ICH days, Claire Gilbert lecture. Very well taken. But from PG point of view, I would like to add on some component along with this. One thing that you understand the definition of child. As per WHO, child means up to 16 years of age or 15 completed year. UNICEF defined it differently. From UNICEF point of view, it is up to 18 years of age. uh, the student must understand that the childhood blindness, though the prevalence is very low, still it is important. Dr. Rohit mentioned about blind years. So we use a term called DALY, disability adjusted life years. So this is maximum, like after cataract, childhood blindness is number 2 as far as eye diseases are concerned. So disability adjusted life years is high. That's why childhood blindness is given importance not only in NPCB, but also through Vision 2020 Right to Sight program, the global program also. We usually ask question how to assess childhood blindness. Population-based surveys are very difficult and they are very less. In fact, in India, till now, only I remember of just 6 surveys, population-based surveys conducted in last 30, 40 years. We did one survey in Delhi, and as per that survey, for blindness, you need a very, very high sample size, childhood blindness. You need a sample size of nearly 1 lakh population. That's why it is not feasible. The prevalence is around 0.4 per thousand. Is the prevalence of childhood blindness. Nowadays, WHO as well as NPCB, we prefer to use childhood visual impairment rather than childhood blindness. If we see the visual impairment, the prevalence is around in children is around 5% of children, less than 6 by 12 is the cutoff. Nearly 5% children are visually impaired. And refractive error, specifically the myopia, is the most common cause of childhood visual impairment. Nearly 90% of childhood visual impairment is due to myopia. So you can understand what is the most important priority among children. So beside population survey, we say if we aware of the under 5 mortality of any country, that gives the prevalence of childhood blindness. Higher is the under 5 mortality, higher is the prevalence of childhood blindness. Beside this, we can do survey in rehabilitation programs, and plus, as Dr. Rohit mentioned, KIM, key information method, is itself a methodology to assess childhood blindness. And where, as he mentioned, that ASHA workers, we have nearly more than 1 million ASHA workers in India right now. And probably they can be used very well as key informants to assess the childhood blindness in any community. Only thing is that they need to talk to the parents of children, and they usually visit house to house. And they can easily assess the burden of childhood blindness or even visual impairment. If we can teach them how to take vision in children above 5 years of age, even that is also possible. And we can actually assess the burden of childhood visual impairment along with childhood blindness if we are properly using ASHA worker. ASHA worker can be most effectively used in assessing and providing vitamin A drops. Nowadays, of course, vitamin A deficiency may not be considered as a public health problem in India now, as per the recent survey. But still, vitamin A prophylaxis program is going on in the country, and we are giving 9 doses of vitamin A till the 5 year of age. Like first dose is given at 9 months of age along with measles vaccine, second at 1.5 year of age, and then every 6 months till 5 years of age, total 9 doses to all the children. This is a vitamin A prophylaxis. It is not treatment. It is prophylaxis for all the children in the country actually. And
That's great. Yes, sir.
these are, and I would also like to mention about the NPCB role actually. NPCB give priority to childhood blindness, and in fact the school vision screening program was started way back in 1994 in India. Of course, Hans Limburg was the key person who initiated this program, and currently we have a target of 15 lakh children to be provided spectacles free of cost under this NPCB through school vision screening program, 15 lakh children per year. This is the target for school vision screening program. And RBSK, it is not part of NPCP. It is a different program under Ministry of Health. It is Rashtriya Bal Swasthya Karyakram. And under this program, specifically under children under 18 years of age are covered. And for cataract surgery and for ROP, these are the two important diseases that has been covered under RBSK, and free treatment is available for both these diseases. Even in Janani Suraksha Yojana program, all the children under 1 year of age provided totally free of free treatment under Government of India. So these things are expected of PG student, that they should remember these different components. Thank you very much.
Great input, sir.
Mhm.
Dr. Subhasini, ma'am, your inputs, ma'am. Ma'am, please unmute yourself, ma'am.
Dr. Rohit, it was a very good overview of childhood blindness. So, from the resident point of view, as you were telling that 60% of the childhood blindness are unavoidable. So we need to know, the residents need to know what are these causes. So under this comes this microphthalmus and anophthalmus. And then we also have the CVI. So this is an emerging diagnosis, and somehow it's sort of underdiagnosed. And since this unavoidable blindness, this group, occupies major component, that is almost 60%. So rehabilitation of these children is a very important thing. So it's not only rehabilitation in the rural areas, which is not happening. So even in tier 2 and tier 3 cities, like for example in Pondicherry too, so rehabilitation is an important aspect, which even when we want to do, we are unable to offer the parents which are the places that they need to go to. So especially in children where there is irreversible blindness, so we can't do anything about, we can't treat them further. So for example in childhood glaucoma too, so when the vision is very very less, so what kind of rehabilitation can be given to these kind of completely blind children? So this is something which
Yeah, yes, yes, exactly. One more thing, recently, what we did in our institute was we had a CME for the pediatricians around, because for every child, the first point of contact is the pediatrician. And we try to explain to them if they can even just ask the parents whether a eye checkup has been done, so that at least they are told by the pediatricians that if you have not had this done, this is also part of a routine checkup, even if the child is not complaining. So somewhere if we can involve the pediatricians also, maybe that can probably just help. And one more thing, as our AI through AIOS or something, can we have a representation to the government to make a single eye checkup per year compulsory for all children from wherever? I mean, cost is not an issue, whether private, public, anywhere. So if the child can present a eye checkup report, so at least because of that, an eye checkup gets done and their vision at least gets checked. Just a thought.
I think this is easy to say, but if we see number of ophthalmologists and optometrists in the country, Dr. Rohit just mentioned, we did this survey in 2021. And as per that survey, currently we have around 21,700 ophthalmologists in the country. And we specifically asked, this was sponsored by Orbis, and we asked about their experience, like whether they also do practice childhood pediatric ophthalmology. So nearly 30% of them, 6,000 ophthalmologists, they mentioned that they practice pediatric ophthalmology. So this only 6,000 is the maximum number which we can say is people who are practicing pediatric ophthalmology. It will be extremely difficult to examine, see the total number of children. It is 20
I agree.
of the Indian population. 20% of population means 28 crore children are there. So you
Sir,
can
but nowadays, sir, sorry to interrupt, but nowadays a lot of people also get checked from optical shops. I
see
mean, I
optical shop
understand, but
also, optometrist is another important area, but number of qualified optometrists, even by their association.
right.
In our survey, from secondary level and above, we got only 17,000 optometrists who have done minimum 2 year of course.
Yeah,
17,000.
which is also not ideal because a routine optical will not be able to give the correct prescription anyways.
Optometry associations, the total around 80,000 optometrists in the country. This is the maximum number reported in our.
Yeah,
So the lack of manpower is something, one important component because of which government of India is not able to say that it is mandatory to examine. Then it is our responsibility in that.
Well,
Right?
I think Praveen well said. I think I will just go back and say in terms of like you brought a very important point, myopia, which is booming up. I
Mhm.
think you have now like myopia clinics being set up at different hospitals, and
Right.
myopia is coming out. Myopia and ROP are like emerging causes and diabetic retinopathy. These are like in adults, it's diabetic retinopathy, which is increasing at a rapid pace. and especially in children, myopia and this in ROP also. So
Yeah,
in terms of myopia also, we see a lot of regional differences. In terms of rural areas, when we go, hardly we see any myopia. When we went to rural areas in school screening programs, the myopia was less than 2-3%. But when we went to urban areas, it was very, very high. So probably it's like something more up to the awareness related to myopia in schools and to these children. And the second thing, what was in terms of causes, actually, I think Dr. Herur, the causes can be for the postgraduates. I think they can divide the cause as whole globe anomaly, which is like it's basically a WHO classification which says that whole globe anomaly, cornea related causes, and then you go to next is uvea, then is lens, then is retina, then is optic nerve. Probably you can go from front to back of the eye and then
right.
classify the causes. The whole globe will include conditions like microphthalmos, buphthalmos, cryptophthalmos, and all that kind of thing. And corneal will include keratoconus and corneal opacity. And in terms of lenses, congenital cataract is very common. Even if they know about that, I think that will become very important cause. And second is like retina is dystrophies, RP and ROP, and these are the causes. Optic atrophy, and in terms of where the child is absolutely normal, it's CVI. I think CVI should be CVI should PG should not postgraduate should not miss CVI. Probably CVI is one of the most one of the very emerging cause of childhood blindness and visual impairment, and I think that is something we should be aware of. In terms of what you said, everybody should go for a eye checkup. I think there is a school health program which is happening, but I am not sure all the schools are covered because it's not the. I don't know whether we have the capacity, as Praveen was saying, we don't have that capacity to take care of all the schools, all the children in all the schools. So probably at least once in 2 years also it happens. I think I'd be glad actually if they do once in 2 years each school.
In fact, for school eye health program, I would like to give some more information. As I mentioned, currently we have kept target of 15 lakh children. But if we assess the burden, we did a meta-analysis of all like studies for last 40 years. And at present, the minimum burden we can take around 8%, 7 to 8% school children, they have refractive error. And this I'm talking about pre-COVID time. If we use even this number, we require 2 crore spectacles every year. If we assume that each child is requires one pair of spectacle per year, then we need to provide 2 crore spectacle per year. So you can assess that the actual need is 2 crore spectacles, and we have kept a target of 15 lakh.
Just 15.
7.5% of the actual need. And there are
Or
reasons. There are reasons, as we mentioned,
yeah.
manpower is the key reason for this.
And you have to keep replenishing the spectacles because children will not, spectacle will not last more than a year, 6 months.
Correct.
6 months is a long time
Yes.
for child spectacle to last.
Yeah.
Or maybe each one of us should adopt one school. Like in our center, we do at least one school every year, screening of all the children. So maybe as a societal obligation, we can all do. These are just
And I
See,
would
thoughts.
say if
from
you
PG
want to,
point of view, sir, one more thing. It is the effective refractive coverage, which is taken as a global indicator nowadays, along with effective cataract surgical coverage. Unfortunately, for our country, we don't have baseline data on effective refractive coverage, specifically in school-going children. I'm happy to share that now AIOS is planning to do a nationwide survey involving Government of India that is on to assess the effective refractive coverage among school children. Hopefully, we'll start this survey within 2 months of time.
Great.
It will take 1 year to conduct this survey. This is initiative of All India Ophthalmic Society.
Oh,
just for your
great.
information, actually, we just published our last year we published effective refractive error coverage in school children. But that was basically from state of Telangana and Andhra Pradesh. So
Right.
Oh,
like 62% was the effective coverage. It is published in Eye Journal.
Mhm.
So that's only, but if you are doing nationwide survey, it will be good actually to have the nationwide data because
yeah.
Telangana and Andhra may not be representative for the entire country.
Right.
But it was a very massive program. We had 1.4 million children data, which
Mhm.
had looked at the effective refractive error coverage in these children.
Right.
Just wanted to ask about cortical visual impairment, CVI. Is there this, I mean, is it partly treatable? And what is this delayed visual maturation? So then how do you approach that? So if you can throw some light on that.
Any pediatric ophthalmologist in this group?
Frederick is there.
Frederick will all look at.
Yes, we do. This delayed visual maturity is basically it's a transient. Just like we have delayed milestones, we see people with a mild cortical, I mean hypoxic features. They initially develop some delay in visual milestones also. So that we usually treat by these images a light in a dark room, and we try to give them vision stimulation exercises. We do see improvement over a period of 3-4 months. But with respect to CVA, it's really difficult because even assessing what the child is having as a residual vision or whatever they are aware, because they do also have multiple problems like defective hearing, defective cognition, or even
Chronic
defective.
features.
Yeah, so we are finding it now more difficult to assess these kids. So we have separate vision therapists and specialists who are getting trained now. Maybe when these people, when they come up, they'll be also included, like of optometrists. We'll be having them in our practice to assess these children, so that we'll be able to provide them with some rehabilitation. It's more of a rehabilitation rather than
Treating.
actually help. We do see the children improving over a period of time. Dr. Vijayalakshmi in Madurai, she has taken it up as a challenge, and they developed a good CVA clinic now. And still, we still are struggling to really deal with these children. So slowly, we are also trying to learn how to assess them, and we really have to spend a lot of time with them. It takes around like
Yeah.
1.5 hours to really know what is their capacity, what are the color problems they're having, visual field problems they are having, and whether they get better treatment with spectacles when they see down, or all these things. It requires a lot of chat time to
Yeah,
evaluate
most
them.
of these children have cerebral palsy and
Yeah.
they manifest as CVI.
And they also have these other disabilities. They are not able to sit properly or walk properly, or even they have other delayed milestones like speech, hearing, and all.
Great
So
discussion.
even though we are now worried about school screening, as we know that there is a very large unmet need, but still, I think we have to go a bit down into the play schools, Anganwadis, and even into the neonatologists units to really make sure that these children are really taken care of, and it's more of a prevention rather than trying to treat these children, especially the CVA children.
I think
Even treating.
dealing with the problem of child blindness requires a multi-pronged approach, and probably one solution may not fit to all of them. So probably school screening as a separate vertical, rehabilitation as a separate vertical, identifying going to special school. There is no program for screening children in special school. Still, there is no program. We did in Hyderabad almost 7,200 children we found in special school, but there is no program by government to go, and we find a large amount of like CVI and refractive error in this children with special needs. Probably that is something which is another area, using key informant approach to find children with pediatric cataracts and all, and retinoblastoma, congenital glaucoma, because these are very, very small numbers. Glaucoma 1 in 1,000 children will have, and retinoblastoma similarly 1 in 1,000. So identifying this one child in 1,000, ROP is a separate vertical. You have to look at ROP in a separate vertical box. Myopia is a separate vertical in terms of preventing myopia and even treating myopia. Now it's like so much of advancement has come in treatment of myopia. In terms of prevention, in terms of vitamin A and measles vaccine, I think is a separate program. So it cannot be like we cannot have one solution for all. Probably we have to look at each condition separately. So probably as a postgraduate, you can look at prevention, treatment, and rehabilitation into 3 components. Prevention in terms of prevention and early detection, you can say, and health promotion, because the awareness creation, preventive in terms of vaccinations and health promotion, and early detection, treatment in terms of diseases like cataract and all, and then probably rehabilitation and ROP in terms of prevention and treatment. So I think you have to list out the conditions, look at what are the strategies, causes, and then probably develop strategy for each cause separately. I think that will give you a whole picture of what a child with blindness. For your exams, I think that will be sufficient in terms of like at least you can get this. These are the causes and these are the strategies and these are the way to prevent, treat and promote and rehabilitate this child. I think that would be good enough for you.
Even in treatable
Excellent.
conditions, treatable causes, when we manage childhood cataract and glaucoma, the main thing is the post-operative care.
Yeah.
So how we need to stress on that, and then the follow-up. These are the main challenges, and how
Yeah.
to educate the parents about this. So this is a totally different aspect that needs to be considered.
Yes, thank you so much. An excellent discussion today, and I'm sure all the postgraduates would have really benefited due to this discussion. Thank you so much, Dr. Rohit sir, for the excellent presentation. Thank you so much, Dr. Frederick sir, Dr. Praveen sir, and Dr. Subhashini ma'am. Thank you so much to our chairman, ARC, Dr. Prashant, and our AIOS president and the entire AIOS team for coming up with such lovely, innovative ways in order to improve the quality of education in our postgraduates. Dr. Prashant, your last few words.
No, I think you have summed it up. Thank you, everyone. Thank you, Rohit. Especially you had to make a lot of effort to compile everything. I know it was all ready. You had to just collate it to bring it together. And of course, all the busy people, Dr. Praveen, Dr. Subhashini, Dr. Frederick, you all made time available at this hour. It's your family time and you have spared our time for our postgraduates. That's a part of your commitment. We are so proud of having teachers like you, and I'm sure the postgraduates must have benefited in a big way. And so a big thanks from on behalf of AISARC.
Thank you,
Thank you.
Dr.
Thank
Prashant.
you.
Thank you so much, everyone.
Thank
Thank
you.
you.